following additional functionality across all GP clinical systems: the capacity to import or download data on a patient's medicines and allergies with Access Record, send document, which allows the systems to automatically send a consultation summary back to the patient's registered practice in the form of a PDF document detailing the consultation and the actions taken. These products will save time for clinicians and provide better, more convenient care for patients. It will also help to meet targets under NHS England's Improving Access to General Practice programme. Any good? I'm sure you guys can hear me on Teams. Are we able to broadcast? Good. Can we do a quick test? Are we able to broadcast? Good. Can we do a quick test?
I'm ready.
Okay, so we just start broadcasting then. Thank you.
Tell me when we're on.
Okay, we're ready. Thank you.
So can I start, Nama?
Yes, please.
So, good evening, everyone. I'm Andrew Frankel. I'm one of the nephrologists working at Imperial College Healthcare Trust, and one of the team of nephrologists working across Northwest London. First, I'd like to thank you all for giving up an hour of your time to talk about chronic kidney disease, which clearly is a subject that I think is very important. And what I want to do is to start by putting up some slides and taking you through a presentation. So if you just bear with me while I just upload my slides. I'm hoping you can all see that. So what I want to do, CKD is common. It occurs predominantly in conjunction with other long-term conditions. And sometimes it gets lost because it is the diabetes or the heart disease or the hypertension that we're concentrating on. However, it is really important that we manage CKD appropriately, because if we don't, it has really significant implications for the patient in terms of their cardiac prognosis, and also for us as a system because of the costs of managing CKD. I'm not going to give a formal talk on CKD today, but we'll start by making sure you're aware that it's common, and it's likely to become increasingly common as we become better at managing cardiovascular disease. So what I want to concentrate on today, and I'm going to be giving the first part of the talk, and Victoria Hanson, the Northwest London CKD specialist nurse, is going to be given the second part of the talk. And between us, what we want you to leave here with are the following, understand the following objectives. To at least begin to understand where you can identify resources that will help you manage your patients with CKD, both in terms of individual CKD and in conjunction with other long-term conditions. And the second is going to be talking about the new virtual Northwest London virtual consultation service that we've launched, and to really try and give you some confidence about how this works and how to navigate referral pathways for people with nephrology problems. And then the second part of the talk, Victoria is going to actually talk to you from a very much a patient perspective, but very much about how we can encourage and support self-care for patients with CKD and understand the key education objectives for this group of patients. And given the fact that we are now working in a very different environment with COVID-19, most of my work is done by virtual clinics or remote or video clinics. Making sure that we have actually encouraged patients to become self-caring is a real priority. I've just realized that I can't see my chat line, so I'm going to ask if Naman can interrupt if there are any questions. It might be best that we leave the questions to the end of my section and then the end of Victoria's section, then we have a discussion at the end. But please, if you have any questions, place them in through the system and they can be passed on to me. So this next slide, if you're going to take any notes, you might want to take a note about this. When I run my clinic on a Thursday and I have a new SHO every week, this is how I tell them is my navigation, my pathway to how we manage CKD. And I think for you, elements of this are very important. Although I would say that the final element is clearly for secondary care. But if you can think about CKD in these terms, firstly, recognizing it. Secondly, diagnosing. And what I mean by diagnosing is what is the underlying cause of the CKD? In the majority of cases, it will be hypertension and diabetes. But there will be a significant number who have other causes that require different management approaches. Immunological disorders, genetic disorders such as polycystic kidney disease. Once we've recognized it and diagnosed it, we optimize the patient, and we do that by means of ensuring they have appropriate blood pressure control, that they are on ACE inhibitors or angiotensin II blockers if that's appropriate, that their glycemic control is appropriate if they are have diabetes, and so forth. And for most patients with CKD, this is the key to how we manage the patient. It's nothing more complicated than that. What I want you to appreciate, because this is where Victoria is coming from, and I'm sure you appreciate this in primary care even more than we do in secondary care, is that you can never really optimize the patient by prescribing a management plan. You can never optimize a patient by telling them what their blood pressure should be and what medicines they should take. You will optimize them by trying to ensure they best understand what the aims and objectives of their treatment are and how to realize those aims and objectives. You also, when you're managing CKD, need to reduce cardiovascular risk, because the presence of CKD greatly increases cardiovascular complications. We then come to the fact that over time, the patient develops complications of CKD. Now, most of these complications, I do accept, should be managed through secondary care. But occasionally, patients who are being monitored in primary care will develop anemia or bone disease, and they do require some secondary care input. Once you have diagnosed and optimized, most patients stabilize and don't require any other intervention other than monitoring. However, a percentage of patients will progressively deteriorate. And that's what you're monitoring for. You're also monitoring for the fact, although you can't really monitor for this, that these patients have a higher incidence of acute kidney injury. But you're looking at declines in kidney function over time, so as to pick up when we need in secondary care to start working with you and the patient to plan end-stage renal failure treatment if it is indicated. So supportive therapy, which is one of the end-stage renal failure treatments, may be the key treatment for a patient who has got profound mental dementia, elderly, frailty in a nursing home. And you have to make that judgment. So you're monitoring to ensure that we don't miss this patient slipping into end-stage renal failure. Can I just say, one of the toughest jobs for you is monitoring. It's easy for me, because if I've got a patient, I give them a 6-monthly, 3-monthly, or 4-monthly appointment. They come along and I do the bloods in a usually stable situation. You are often trying to capture the patients when they appear to monitor according to guidelines. And of course, creatinine and GFR are very noisy measurements. They fluctuate from measurement to measurement, making it difficult for you to discern whether or not a difference in GFR is real or merely just noise. So GFR will vary if the patient hasn't had any fluid, if they're starving, as they sometimes do when they think they have to have bloods taken. if they've had ibuprofen for ankle pain, or if they've had a high meat meal, a protein meal the night before. That makes your life difficult. So just to summarize, you have to recognize, we have to work together for diagnose the patients. Optimization for most patients is straightforward cardio-renal optimization, reducing cardiovascular risk, watching out for CKD complications, and monitoring so that we can take the patient over if they are likely to need end-stage renal failure treatment. Okay, now I'm not going to talk in much detail now about how we do this, but the purpose of this talk is to point to you where you can find the guidelines that simply tell you what to do. We house all of our guidelines on Hounslow website, and you Google Hounslow CKD. And if you get that, you will find our CKD site with lots of information, but with our key guidelines that has essentially 7 pages, I think 8 pages that you're seeing here. Do not worry about the fact you cannot see any of the detail on this slide. This slide is there for me to tell you where to go and what is on that site. The guidelines are entirely nice, consistent, and they have different pages for different parts of the management plan. The first page is called diagnosis, but actually is recognition from your extent. It's telling you who to test for CKD, how to interpret EGFR values, and has got the classification of CKD as approved by the international guidelines and NICE. It has something on recognition of proteinuria and hematuria. So the first page will have your diagnosis on it. The second page is a referral algorithm. This is sometimes useful if you're trying to decide whether a patient needs referral. I would just say to you, in the world of the modern North West London CKD virtual service, you can ask us anything through that virtual service, and it doesn't mean necessarily that the patient has to meet the criteria for secondary care referral. You can ask questions that are at the borderline, and often that's where these questions are. But this page will give you a very simple algorithm for what should be referred, with the criteria of what you need to provide if you're making that referral. But again, please remember, for North West London kidney care referrals, you can refer anything. If we think it's straightforward, we will just get back to you with advice and guidance very speedily. If it's more complex, we will do a formal consultation in your records. Sorry, I should have remembered it does the... Aside from this, you will find within the guidelines a page on drugs, a page on the management of CKD. And what we also have is a page each on how you manage CKD in the context of heart failure, diabetes, and frailty. Because as I said before, CKD does not often occur alone. So, I want to now just tell you, having told you where you go for getting the guideline, which is North West London Kidney Care, on the Hounslow website, Hounslow CKD. And I wanted to tell you we're now working very, very differently. We're doing a lot more remote consultations, and we have emulated in North West London a model of care that's been introduced in North East London about 5 years ago called the virtual service. The virtual consultation service is different from a remote consultation. Excuse me. From a remote consultation service, it is undertaken without patient's presence. and is recorded directly in the GP records. That is different from a video consultation or a telephone consultation that you are currently undertaking. If you look at this diagram, the traditional pathway is shown at the top. You see the patient, you have a nephrology question, you refer them to a clinic, and in Harrow, they joined a very long waiting list to be seen. And eventually their turn comes, they get in their car or bus, and they come to the hospital and see a consultant. With North West London Kidney Care, you do exactly the same thing. You refer the patient, but you refer it now through a single portal called North West London Kidney Care. And we triage that referral within 24 hours. And we will, because we can have access to the GP records now, as long as you indicate that the patient has given consent, 60% of the referrals we can manage by doing the consultation within the GP records, that is within the community tab of EMIS, sending you an electronic copy of that consultation so that you know it is in your notes in case you do not see it. So it's belt and braces. And as a result, the number of people who need to come to see us in Northwick Park will go down. The results are that patients no longer have unnecessary visits. We can give you consultations or advice within 24 to 48 hours, not 6 to 9 months, which it currently takes in Northwick Park. That reduces stress and it reduces you chasing up appointments. We also will reduce waiting times in the outpatients, and West Middlesex, which used to be very similar to Northwick, has been running this in Hounslow for a year. The waiting time for a nephrology appointment there has come down from 8 months to 6 weeks. And in Hammersmith, Charing Cross and St Mary's, patients can be seen almost immediately. So that's the aim. We will speed up your ability to get specialist advice, and that's for patients. Immediately prioritize those cases that need specialist secondary care input. Help identify patients with non-progressive CKD. And that will allow us, that fourth bullet point is what we can now do more effectively in our clinic. And we can reduce unnecessary visits, investigations, and unnecessary visits to hospital for patients. What I want to get across is that we are not, when we do the consultation, undertaking nephrology in the GP practice. No patients that we do a consultation on in the GP notes have a follow-up. You are given simple advice. The process is exactly the same, except you refer, instead of North West London or Hammersmith, you go to North West London Kidney Care. What you need to do, though, is to ensure that you have consented the patients to share the record, and you record this explicitly in the referral. And we have a particular performer which you can use in Harrow, and some of you are now using that. But even if you use an old one, as long as you say patient consents, we can go along. And finally, you need to ensure that each practice, this is a one-off for the whole thing, has your data sharing agreement with Imperial enabled. And we have a technical advice. Can I tell you that email over there is only for technical advice? And I know that North West London CCG collaboration have sent that email out as one for clinical advice. I'm sorry about that. The numbers of patients that we are seeing, and sorry, this is an old slide, is going up dramatically. We are now rolled out across the whole of North West London, and I can tell you that for June, we were at 150, and July, we are heading for 190. And 50% of patients have virtual reviews, 37% have face-to-face. Where it says rejection, this is predominantly either the referral is not necessary or we can deal with it with advice and guidance. We will still have our e-advice service open, and this is where you can go for e-advice. But over time, we are looking to merge these two, And we are working in Brent with Rego to ensure that when that is launched in Harrow, there will be a single portal for you for nephrology opinion. I'm now going to pass to Victoria. Victoria, I'm not sure if you are.
I'm here. I'm ready to start.
So I'm going to now mute myself and turn my screen off, and I'm going to pass to Victoria, who's going to talk a little bit about the work that you do.
So, good evening, everybody. Part of my role is to organise teaching sessions, education sessions for GPs, nurses, and of course patients. With all of the teaching, as Andrew was saying earlier on, there's a strong emphasis on motivating patients to take control of their health and kidney disease. And we, you see here, we use the STEM of kidney health, which I'll explain to you a bit later. But it's basically the S is for sick day guidance, T for targets, E for EGFR, and M for medication. That's the next slide, please, Andrew. So we've tailored education sessions. These are the sessions that are suitable for GP practitioners. We've got a wide variation, and these can be in the evening or daytime, whichever suits you. One of the things that I did do is I went to visit GP surgeries to find out exactly what you wanted from these education sessions. And one of the things that came up was a CKD MDT session. So these sessions are led by GPs, where you bring your cases to the session to be discussed. And this allows a learning experience for, as well as the GPs, the presenting GP will be able to go back to the patient, go back to the practice with a plan for the patient. And we're quite happy to change these sessions around for whatever suits you. Next slide, please, Andrew. Again, I did the same with the practice nurses, and these can be, we appreciate that the practices are very busy, so these can be as short as 30 minutes or as long as a whole afternoon. For diabetes and kidney disease, our diabetic nurse specialist kidney diabetic nurse specialist has agreed to run a joint session with me as well. Next slide, please, Andrew. The other thing that I was asked for was some education sessions for practice managers and receptionists. And I think it is quite important for those, for everybody to know how difficult it is for a patient to organise slots, to organise an appointment around dialysis slots, for example, or how important it is for a transplant patient to get antibiotics for their UTI. But I think that one of the other things is important for everybody to know how a lot of these patients who have a chronic illness are suffering from depression, and how to be mindful of that. Next slide, please, Andrew. So in these COVID times, everything has changed, obviously, and teaching, so that this has its advantages and disadvantages. But one of the advantages is that more GPs and practice nurses can attend education sessions online. I recently attended a training session where we were allocated into different rooms online, and the tutor was able to pop in and out of the room to see how we were getting on with the tasks we were set, and then we were all brought back to the main session. So there's plenty of scope for this. And surprisingly enough, our elderly population has managed with this new technology which has been forced upon them, which is marvellous, because, next slide, Andrew, it means that we're starting to think about presenting online group sessions for our patients. And this is something that you will be able to refer your patients to as well. So these education sessions, we start with a talk about learning about the kidneys and what they do. And this is followed by education about how to look after your kidneys. So we have a physio who will talk about exercise, a dietitian to talk about healthy diet, and also the diabetic nurse specialist will give a talk at these sessions. Most of these patients, to established renal failure, that it's important for them to, but it's possible for them to slow down the deterioration of the disease. And this is by very simple things like living a healthy lifestyle, maintaining a healthy weight, stop smoking, low fat, low salt diet, which you would do for a diabetic and anybody with hypertension. Next slide, please, Andrew. However, the patients, most important, they need to know that they have CKD. And I'm not sure everybody is comfortable about telling them this. When I have done my teaching sessions at nurse forums, I've found that about 90% of the nurses feel that it's not their job to tell the patient that they've got CKD, even though they can clearly see a decline in the function. I've spoken to a few GPs who tell me that they tell the patients that they've got a bit of kidney damage, but not to worry about it. And I'm positive that most of those patients are only hearing that they don't need to worry about it. So if we want patients to take ownership of their CKD and to manage it, then they need to know that they have it. Next slide, please, Andrew. So the STEM of kidney health that I was talking about earlier, the S is for sick day guidance. And it's essential, particularly when thinking about preventing AKIs, for patients to know if they do become unwell, which medications to omit, what to do about their diabetes. T is for target, looking at that you don't want to have, for example, patients think, oh, well, I've got to get my blood pressure, I'm a diabetic, I've just read, and I've got to get my blood pressure to 120 on 70. Well, this wouldn't be appropriate for an 88-year-old man, for example. So it's important for each patient to have their targets and know what they're aiming for. It's all very well asking a patient to lose weight, but you want to give them something to aim for. And I've often found when I ask a patient what their HbA1c is, they don't even know what it is. So it's important that they know what it is, and what they're working towards to make an improvement. The EGFR, the level of function. So I often find that when patients are coming to my clinic, they want to know, that's the first thing they want to know, is what their EGFR is. They become focused on it. And they all they love a printed out chart. So they do get engaged if you start talking to them about it. On medications, if we want patients to, if we explain to patients that their blood pressure is so important, they need to know what medications are for their blood pressure and why it's so important for them to take it. Next slide, please, Andrew. So there are plenty of leaflets and resources for patients out there. Many of these are free, certainly from the Kidney Federation. You can get as many as you want for free. Bearing in mind that it's so easy to hand out leaflets, and there are lots of patients who perhaps with language difficulties don't understand what they're reading or are illiterate, for example. And there are websites that you can go to. There's a lot of information. I don't know whether any of you have had time to look at the Know Your Diabetes website, which is absolutely fabulous. And there's little video clips as well. One of them I noticed is about the Harrow Striders, which is a walking group that has grown from one man who started to exercise. Care Information Exchange is a resource that we are encouraging our patients to use. And this is a resource where patients can look at their own blood results and also look at their hospital letters. If we can put on there information that's tailored specifically for them. So if we wanted to give them something about their particular diet, we can send it to them on Care Information Exchange. They, in turn, are able to, for example, if you ask them to record their blood pressure for a week, they can put that information onto Care Information Exchange, and you can read it from their clinic rooms. Next slide, please, Andrew. So, as mentioned before, we need our patients to take control and ownership of their disease. And we've published a few leaflets at Imperial. One of them is, which is the most important for CKD, is managing blood pressure. And we encourage our patients to do their own blood pressure at home. This leaflet explains why they should do the blood pressure, how the blood pressure affects the kidneys, and then there's this step-by-step guide as well, so they're doing it correctly. My email address is on there, so if you want, I can send you an e-copy. Next slide, please, Andrew. This is a photo of a 6-day guidance magnet. This is a fridge magnet. It's about the size of a postcard. And it was suggested, a patient suggested it actually, and it was really quite easy to do. So in a very simple, short few sentences, it explains about which tablets to stop, to omit, for how long, when to seek medical advice, those special things to do, what to do when you're diabetic. Yeah, next slide, please, Andrew. So I hope that we've covered as much as we can in a short period of time. The aim is to know where to identify sources that help you manage patients with CKD, that you now feel more confident about referring patients using the CKD referral pathway, and I hope many of you go and look at that then afterwards. And also to recognise how to support your patients with CKD with self-management and understand the key educational objectives. So any questions?
So, Victoria, there's the two of us here now. I'm just seeing if there's anything on the chat. If anyone does have any questions, they can type it in now. Just want to make sure that, again, I highlight to everyone the key messages to take away, which is that CKD, you're going to see a lot of it. We have to work together. It doesn't all need to be secondary care managed. There's a lot of useful information out there that is available on the Hounslow website. So Google Hounslow CCG. One of the cornerstones, though, of managing CKD is making sure that we encourage patients to self-care. In exactly the same approach we've done with diabetes, and we need to start different conversations with patients around knowing their kidney function, knowing their blood pressure target, knowing what their treatments are. If we do this, we can engage patients. I'm happy to take any questions, particularly if there are any around the new process, if anyone's has referred patients. Okay, no, ma'am, we've not sure if the link is working. I'm assuming it's working to the training site. Hopefully then that means that everyone is clear about things. Now, is there anything you want to say or anything else that we need to add?
Not really, no. Thank you very much.
Okay. If there are no questions, I would remind you that you can get all the resources through the Hounslow CCG website. Any questions about the new North West London virtual service? There was I'm very happy, Naman, to share the slides so that people can get Victoria's email address, the e-advice address, and the technical address, and can contact us if there's anything they want. Is that all right, Naman?
Yes, please. Thank you very much.
Okay. Well, then, since there are no questions, we can all go and get an early supper and perhaps an evening drink. Victoria, thank you very much. Naman, thank you very much for inviting us.
Thank you.
Right.
Bye-bye.